Manchester. Policy at Manchester is the impact wing of Manchester University, which brings the knowledge and expertise of Manchester University academic policy sphere. So we'll be hearing later on from Professor Arpana Verma of Manchester University. But yeah, that's, I think you're coming third in the running order, Arpana. We're here to talk about health inequality and the digital revolution. You're aware of the broader issue, of course, of health inequality, probably one of the biggest challenges for levelling up, possibly even so big it doesn't even quite come into even the expanded remit of Michael Gove. But if we're going to talk about a levelled up country, surely we have to address the fact that some of us will sadly die earlier than others by reason of the place where we are born and the economic position in which we find ourselves. So that's the big framing idea here today. The housekeeping before we actually get into the stuff you can listen to. That camera over there is currently live streaming us to YouTube, the SMF's YouTube channel. So hello to the live audience joining us, who will later on be able to contribute questions via something called Slido. Apparently, I have no idea what it is. So we may get some questions from the Slido community. All of you in the room should know about that, because when we get to the questions later on, you are not just talking to the brethren in this room. You're also talking to the infinite internet out there, and your questions will be preserved for all time online. So bear that in mind when you do get questions. Also, when you get questions, please do ask questions, not speeches, or I'll shout at you. I don't like speeches, except from the panel. Other housekeeping I'm going to do. If there's no fire alarms planned this morning, so if bells and whistles go off, just run screaming for that door over there, or it is that one actually. That one, but that's about all from me. I will start handing over gracefully to our panel in a second. In terms of the running order, we're going to hear from Lord Bethell, first of all, as the recently become former Minister for Innovation. He will then, in Doctor Who-like transformation, hand over to George Freeman, the Minister for all things clever, innovative, scientific, and the betterment of our country. We will then get our experts, Arpana, Tim, and finally Helen from the Good Things Foundation. I'll let them all explain to you why they're marvelous people you should listen to. I won't do the introductions and titles. So that's given us a big illustrious panel of interesting people. I promise that will be the longest bit of talking you will hear from me for the next 54 minutes. So with no further ado, the Lord Bethell.
James, thank you very much indeed. And can I just thank SMF for hosting this event? It really is such a relevant and pertinent subject. We just can't talk about health, tech, and digital enough at the moment, because we have huge ambitions to achieve longer, healthier lives. And that's not just for a few people who goes to GP every month, it's for absolutely everyone in society. And we're just not going to achieve that if we don't get this stuff right. Now, I just stepped back from the front line of the pandemic response, and I saw for myself how data and tech in the health sphere can have an absolutely awesome impact. The really high-profile things were things like the digital vaccine certificates, the vaccine itself, appointments by Zoom, proximity apps, the powerful data visualizations we saw from number 10. I mean, those were really trophy examples. And there were, behind that, innovations in AI and genomics and big data that were deployed in diagnostics, therapeutics, surveillance, sequencing, vaccines, which saved thousands and thousands of lives and ultimately helped get the country back on its feet. But it was in the area of inequalities that I had the most powerful sensations and experiences, because every day I sat in meetings with the healthcare system, where there were graphs that demonstrated the wards were filling up day after day after day. The ICU limits were being approached, and the people often in those beds were the people who had obesity, who had weak hearts, who had long-standing comorbidities. These were the people who were ill before the pandemic hit us. And we were in a situation where our healthcare system was struggling to meet the challenge because we started in such a bad position. And we also sat in meetings almost every day with maps showing how the disease spread around the country. And so often it was exactly the same communities, the communities with the worst housing, the ones who struggled to make ends meet, so they were obliged to go out to work, communities where there was high prevalence of illness in the first place, and for a whole host of reasons which we can discuss, probably didn't have a very strong connection with their local healthcare system. They just weren't plugged into us, and they weren't listening when we tried to speak to them. So I came to realize in a really visceral way that the health inequalities of this country were costing us an absolute fortune. A day of lockdown cost this country £4 billion. And for the sake of a few thousand ICU beds, we were bringing harsh measures that hit this country really, really hard in society and in the economy. And there were two impressions that really, really struck me. Firstly, with those people filling those beds, how was it that we've ever got into a state where this country's fitness is amongst one of the worst in the world? The obesity epidemic is very well known, but in many other markers, we start from a very bad position. And secondly, despite the fact we have a wonderful NHS and a wonderful system of GPs and health visitors and public health messaging, I could feel to large parts of the country, we were pulling a lever and absolutely nothing happened. There were millions of people in this country who were not connected with what we were saying on isolation, on testing, on vaccines, and all the basic public health messages that we had. Now, we did make progress within the pandemic itself. To give you a couple of examples on surge testing, we did, by just dint of hard work and focus, really get through to some of the communities I'm talking about. On the vaccine program, the take-up amongst some of the than I thought it was ever going to be. And the non-digital rollout of the vaccine certificate, which we talked about earlier, was also a case study in what you can do with the... But my feelings are that the job is just not done. This is all unfinished business. We've got a massive task ahead of us to address the inequality, the health inequalities of the nation, that were laid out very graphically, if anyone needs an update, in the CMO's most recent annual report. But I am optimistic about this. And there are four reasons why I'm optimistic. Firstly, the PM gets this, partly because of his own brush with death. And programs like the obesity strategy have the right level of ambition. So I think it'd be really interesting to hear from the Minister a little bit about the political will to make a difference. Secondly, I think the health system gets it. We definitely moved from using the phrase hard to reach communities to having a mindset that it was us that was difficult to reach. We began to understand that we had designed a healthcare system that just didn't suit the lives, the culture, or the way of life of a lot of people. And I think that we do have to have a conversation about how we change that. The mindset within the healthcare system is one that I think is open to change, but that is ephemeral, and so we have to build on it really quickly. And I'd really be interested to hear from the other members of the panel about the commitment to the NHS and social care and other parts of the healthcare system. And lastly, on the technology side of things, I saw for myself about the power of data, the recruitment for clinical trials, the shielding list, the effectiveness of tracing, the surveillance of the disease itself. And a really strong example is the prioritization list of the vaccine. We put together a prioritization list, and I never got a single complaint from anyone that they were on the wrong list. Now, that is an absolutely awesome achievement, and it shows the power of data and identifying those who are at risk. And yet we are not using that system on a day-to-day basis. And I just think that there are enormous opportunities for doing that. It all depended on huge data projects, often using very difficult legacy data in new ways. But I can't speak highly enough of the achievements of NHSD, of NHSX, and all the other contractors who helped make this happen. It really struck me that making better use of data is one of the ways in which technology and data can be used to reach people who aren't currently plugged into the system. And I would really welcome reflections from the panel on that. Thank you, James.
Thank you very much. This is a self-chairing panel. This is marvellous. I promised a seamless transfer from former minister to current. I should point out that, of course, we are talking about transfer of departments because we've gone from the Department of Health to the Department for Business Enterprise. What are you called these days? I forget. The BASE department, which
Business, Energy and Industrial Strategy.
That one, yes. All the more pleasing that George is here to talk about health from the perspective of a non-health department. I think we all agree that when we come to health inequalities, this is not just the job of the health department. So I'm extremely pleased to have you here as a business minister as well, George. So I'll hand over to you and get your thoughts, George.
Thanks, James, and thank you to the SMF for holding this and bringing this august panel together. It's a really key topic for all the reasons that my good friend James has just set out. And can I just start by saying thank you to you for all the work you did. COVID, the 18 months of the COVID crisis was pretty testing for everybody. And I know, because I've done your job, but not through that crisis, the pressure you're under and the incredible behind the scenes pressure in the system and your leadership and the energy that you brought to it. And I think we all owe you a big debt of gratitude. There were lots of mistakes made, of course. There were in the Battle of Britain, there were in the Second World War. But the point is, we delivered it, and that was an injection of pace and energy and dynamism, which you were a key part of bringing to the healthcare system. So thank you for it. Look, I think you've set the scene brilliantly. Let me not repeat the same point, but just firstly on the portfolio, when I was Life Science Minister, a position that I managed to persuade David Cameron to create back in the coalition, because it seemed to me we were never going to both really modernise the NHS or deliver a modern 21st century medtech and life sciences ecosystem unless we got the NHS and Department of Business pumping together like a sort of finely tuned Formula One engine, instead of a world which I'd sort of arrived into where NHS was sort of pretty hostile to innovation, really. It saw it as very expensive and a bit of a sort of distraction, machines that go ping from frontline staffing and healthcare and medicines. Whereas my argument was, if we lent in a bit and pulled innovation in more quickly, we could actually get highly discounted prices because we created the NHS as a test bed. And actually industry is more worried about time than money. The NHS is never going to be a high price payer for drugs. But if we could become more of a test bed, then we'd be the place that people would come to internationally and say, look, you don't go to Britain to get the highest price. You go there to get the quickest data on your drug. And as the genomics and informatics revolutions totally transform the way drugs are discovered, we're moving to a world where industry spends £2 billion, 15 years, 80% failure rate to discover a blockbuster, to a world which actually works really well in about 20% of the population, to a world where using genomics and informatics and great medical charities, we can start to create drugs around specific groups and fast track them through much more quickly. But when I was in that role, of course, the first person you need to go and see is the minister at BASE, who's got all the UKRI Research Council Innovate funding. And it's a joy to me now that the life science industry has really got two ministers, one in health and one in BASE. So my portfolio is all the science funding, technology and innovation. And my mission really is to get the science funding machine to hum like a Formula One engine. I don't think it is at the moment. And if we're going to persuade the Treasury to tip more money in, which we must, boy, have we got to make sure that taxpayers know that every pound is being used like Formula One fuel incredibly efficiently. But the real challenge is how do we then take that credible science base and use it to, yes, create a modern economy and build clusters and attract investment, but also modernize public services. And that's why I think this is so important a conversation. So how do we harness digital health is the question for tackling health inequalities. Let's just frame the context, I think, because I think a lot of people out there think of digital health as sort of, Apple Health, Google Health. It's the sort of, it's the worried well. It's the sort of digital fitness apps, the 10%, 20% of the community who really take their health seriously. And that I think even in the health service pre-COVID, sometimes there was a tendency to think of digital health as a sort of tomorrow thing that we need to think about, but it's not actually mainstream to today's healthcare. And I think COVID has changed that. I think that's part of your legacy, James, that the system had to very quickly, as you've described, get on top of the data because the data was the pandemic management tool. And that flushed out a lot of problems, but it also created a lot of huge improvements. And the first point is it would be a tragedy if we slipped back into pre-pandemic comfort zones. We need to keep that digital progress in the system. But I think a lot of people, both in the system and outside, think of digital health as sort of clever startups in Shoreditch and Cambridge, but not mainstream healthcare, and certainly not the windy backwaters of my constituency, Norwich, mid-Norfolk, a blue-collar, low-income, agricultural backwater in East Anglia, and the other backwaters all around the country. Addenbrooke's and the Cambridge cluster is only 40 miles away, but you can't feel the benefits of being in that academic health science tertiary medicine cluster in my constituency. My constituents don't feel it. So I think there's a real challenge. It's a great question to be asking. How can digitalization help us bridge that gap? Well, here are my thoughts. I'm going to start at the research end with clinical trials, but ultimately the answer, I think, is in the population end. But the first and obvious opportunity is the extraordinary leadership and success of this country in the COVID recovery trial. I mean, it's 10 times bigger than the next 10 COVID trials around the world. I mean, Britain just absolutely smashed it. We put together the world's biggest COVID vaccine trial at pace, at speed, and led the world's search for vaccine. I mean, incredible. And I think as someone who comes from a life science background, for the first time in my life, the public have sort of got that slightly spine-tingling sense of excitement about clinical trials. And I think they think of it as a medical Olympiad, and they're really proud. We won the gold medal. And what's really exciting is that if we're going to build on that, as we are, actually clinical trial success is all about patient recruitment, breadth of population, and actually our Cambridge, Oxford, even London centres of medical research haven't always got the population catchment to be able to build at speed. So I think the clinical trials challenge and opportunity is to really build out our clinical trials expertise around the country. And through Genomics England and through all the COVID trial gateways, people around the country can get involved in clinical trials research, because all the evidence shows that that's also the way to improve access to the latest medicines more quickly. And I just point you to the Institute of Translational Medicine in Birmingham, set up by the brilliant Charlie Craddock. He's pulled into the West Midlands about £200 million worth of free, innovative drugs, saved hundreds of thousands of lives by setting up a translational medicine institute. And we can do that all around the country based on clinical trials. So that's the first thing. Secondly, earlier diagnosis. We know the incredible power of these things now to begin to not just tap in how you're feeling, but you can put your finger on it. It'll start to give you your blood pressure. It'll start to, you can look into it with your eye. It'll start to tell you, it'll do a diagnosis for you. Press the button and it arrives on the GP's PC, cutting out rafts of driving to the hospital, paying for a ticket, queuing, cancellations. I mean, we're talking massive savings and huge benefits in terms of clinical treatment. So there's a huge diagnosis piece. And one of the keys to unlocking these health inequalities, which are, let's not brush over it, shaming. As the Prime Minister and Neil O'Brien and others set out this summer, the health inequalities in this country, the cancer outcomes, the longevity, 25-year life expectancy difference between Kingston and Hull. And I mean, really shocking. So we've got to think of some very tangible ways this revolution can help. So second, I think, is earlier diagnosis. Third is the patient pathway and patient safety. You know, an awful lot of patients very diligently, very patiently queue up, go to the GPs who are under pressure because of the backlog, and then they perhaps get referred to a hospital, and they drive and get a bus to the hospital, and they get a parking ticket, and they go through the pathway. It's not often designed for the benefit of the patient. It's designed for the benefit of the system to be efficient. But actually, modern health requires us to create a much more dignified, seamless, caring pathway, not just for the patients, but for their loved ones. So I'm sure all of us in the room at some point have had vulnerable members of our families going through healthcare. I mean, when my mother goes in hospital, I'd like to be able, as her son and with power of attorney, I'd love to be able to see her pathway. I'd love to be able to see your mother's seen the consultant. And, you know, we ought to be able to build both for the system to manage patients, but also for patients to be more aware of where they are on the journey, a digital pathway. And when I go to hospitals and see, you know, vast data reservoirs still of paper and cardboard, medical records with treasury tags, it's not just disappointing, it's really shocking. Yeah. It's really shocking. And it's difficult in government I think often for ministers to admit that there's a real problem, because we hate to admit that there's a real problem when we're responsible for it. But there is a real problem. And we have, when we talk about digital health, I think people sometimes think this is some sort of brave new world of tomorrow where we lose control. The truth is we should be worried today that we're running the healthcare system without the degree of digitalization that we need. If we told you we were running our nuclear submarine fleet, or our defence establishment, or the City of London, or any part of the economy you rely on, with partial digitalization, patchy, brilliant in places, cardboard in others, you'd be really worried. And I think that is part of the message we have to say to people. Don't be frightened of this, be frightened of not having digitalization, because in the end, that's what will drive up standards. And fourthly, and most importantly, population health. And I think these come together beautifully, because in the end, how are we really going to get people in those cities and towns where healthcare has really lagged behind to get on this journey? I think the opportunity for them to enroll in clinical trials, to be part of research medicine, merges with the wellness digital space. So I would love to see us create a framework in which 6 of our big cities, 6 rural areas, become proper disease or place-based digital health portal hubs, where you get a diabetes diagnosis. And boy, do people start thinking about digital when they get a diagnosis. And they say, Mr. Freeman, I'm sorry you've got diabetes, but don't worry, you've joined 2 million other people. Here's your login to the NHS diabetes portal, which is actually probably run by Diabetes UK. Click here to see other patients in your area. Click here to slide your consent for research with Diabetes UK. Click here to enroll in trials. And I think if we use the power of digital to build communities around disease and place, imagine a fitter Manchester, fitter Birmingham, fitter London, where you could start to be part of a community and sharing your health journey. We'd also then create the digital framework for the ultimate key, I think, which is to incentivize places for improving their healthcare. So I'd love a league table of health inequalities and areas that are being held back by poor health, and then reward them for turning that line around and starting to tackle. And I think if we did that, and you'd have the digital metrics for it, leaders would start to say, did he just say that if we can improve health outcomes in this area, we get more funding? Then I think you'd start to create a really exciting world. And if we're going to deliver net zero, we need to link that into carbon credits and incentives for communities and families. If everyone starts to get out of the car a little bit and walk a bit more and cycle a bit more and do little things in a different way, we'll start to build that grassroots movement for a lower carbon economy. Actually, healthier and cleaner growth go together. And digitalization provides the opportunity for us to really reward both families, communities, households, schools on that journey, but also create the industrial framework for leveraging in big investment in new medicine and new treatments.
Thank you very much. We could probably spend all day talking about it. The barrage of points you've just given us there, George. We will get to those in questions. I'm going to hand over next to Arpana Verma, who's the professor of public health and epidemiology at the University of Manchester, but also in terms of one of those seamless transitions. You talked about urban areas where there's a particular problem with public health. Arpana, I think I'm right in saying you are the founding president of the Urban Health section of the Public Health Association. Is that right? Yes, in Europe, and so a genuine authority. Not that our esteemed politicians are not authorities, but we have an expert authority. So your thoughts about it?
Thank you. It's a great pleasure to be here, and thank you so much for that fantastic introduction. It really does resonate with everything. So my background was a junior doctor about 5 miles away from here, and looking at patients who really shouldn't be in hospital and seeing the effect of what was happening outside of the healthcare impacting on the way that people were being treated, and their outcomes really started the passion for looking at health inequalities from a population health side of things. And I think one of the key things that you mentioned, Lord Bethell, was, have we created this system? And this is something that we've been researching into, not just here in Greater Manchester, but within a global context, that we see these inequalities that are actually greater within our cities than between our countries. And being able to really measure these accurately has been a major source of research for us. And as you mentioned, the urban health projects demonstrated how we have pockets of resilience that really are amazing, together with some of the key things that we've been discussing on inequalities that have been exacerbated by the digital revolution. And one of the key things that I think you said is this is a time for optimism, that sometimes I think we get paralyzed by fear of tackling these large problems. But at the moment, what I'm seeing very clearly within our communities is that huge interaction with not just the health and care sector, but also with the local communities co-producing the answers for us. And we were very fortunate to work with the Good Things Foundation and Better Points, thinking about how we do this at scale. And that was a recent research project where we found that we had an inextricable link between health literacy, digital literacy, and financial literacy. And those three key parts of the triangle really were driving some of the inequalities. And being able to untangle that through some of the work that we were doing with our communities and looking at access, because we hate the word hard to reach. And I know that there's a drive now to call these populations underserved, but they hate that.
Yeah.
It's a terrible phrase.
Yeah.
And I think one of the key things that we found is by working with these communities, and we very much appreciate showing you more of what we're doing. It's the local public health teams working very closely with the voluntary sector, working with health and care sector that actually is delivering some of these key advances and making our communities resilient. I'm so glad you mentioned clinical trials, because from a very early age, it was absolutely evident that people that are recruited into clinical trials have better outcomes, but yet the people with the poorest outcomes weren't being recruited into clinical trials. And with the work that we've been doing with biomedical research centres and the clinical research facilities here in Greater Manchester, it's really been fantastic to work with communities that have really focused on how we are accessing those communities to bring them into things like clinical trials and innovations. And I think some of the issues that we've discussed have very much focused around nomenclature. We get so bogged down in digital exclusion. And I think we also get confused between digital exclusion and digital competence. We know that there are vast amounts of people who are digitally linked through social media, through things that we perhaps haven't got access to, that have the competence, but then it's all the things we've created around the system that prevents the access to allow us to look at how we include them into things that might help in terms of a disease or being able to do early detection. But also what we're absolutely fundamentally needing to do is that prevention agenda.
Thank you very much, Arpana. Now, one thing, I don't know if you're currently in receipt of some of the research funding that George is now in charge of, but I'm sure hopefully by the end of the hour we can arrange for you to be, we'll make that a KPI for the session. I'm going to hand over next to you to Tim Barker from Kooth, who will talk a little bit about digital and mental health, which is an aspect of this we haven't got to so far. But Tim.
Great, lovely to be here. Thank you for coming today. So yes, I think I can give you the voice of the service provider. We are an innovator. Kooth is a 20-year-old company founded in Manchester, now with offices in London. We floated on the London stock market last year, so we are a corporate with social impact. Perhaps there's three things just responding to the topic of discussion to talk about. One is about the role for digital in whole population health. Perhaps one is around service design. How do you go to design a service that can really be adopted and used and valued across society? And thirdly, the use of data. As a digital service, we radiate an abundance of data. And so perhaps to talk about how the NHS is already taking this data on board and using it. Just a few stats for those of you that don't live and breathe mental health every day as I do. Clearly, over the last 18 months, one of the victims of COVID has been the nation's mental health. Right now, there are 1.6 million people on waiting lists to get mental health care. Behind them, there are 8 million people that raise their hand, but are not yet sufficiently mentally ill enough, if you like, to really get specialist support. 9.6 million people in England alone is 17% of the population. And clearly in areas of deprived areas, in rural areas where services are hard to reach, you'd expect that prevalence to be even higher. So it's invisible to many of us. Half of us would never talk about mental health. Yet you look at Gen Z, there was some research in the Sunday Times 2 weeks ago. For under 25s, it's the #1 topic they're most passionate about. More so than the environment, more so than COVID. Mental health is something that now is being destigmatized and is now becoming a lot more open as a topic of discussion. And as a digital service, over the last 20 years, we've really pioneered and partnered with the NHS to help provide and expand access to professional healthcare support. Our service is commissioned by 90% of commissioners across NHS, clinical commissioning groups. 200,000 people used our service last year, and we have a specific focus on children and young people, 10 to 25-year-olds, because poor mental health, 75% of people that have mental health issues, it starts in those formative years. So if you're going to tackle this over a generation, you're going to start by supporting young people. The benefit there is that you can really design a service which can be reached by all. And maybe to talk a bit about service design and how you can grow that usage and adoption. We designed Kooth based on 3 foundations, 20 years ago. One is there is a stigma in asking for help. So you don't want to start by linking this to an electronic patient record. You want to start by making an anonymous service that you don't need anyone to know that you need support for. So anonymity is really important. Accessibility is important as well. So that means if we just build something that supports everyone with a smartphone, we're excluding anyone else that just has basic internet. So making sure that it works on the web, on any device, as opposed to just working on smartphones alone. And the third thing is if you are going to support whole population health, you need to design a service that is going to be engaging and welcoming. So there is a line to tread there between it feeling like a clinical service and something that will drive adoption and usage. A key part of this, for example, is part of our services there as a community. Kind of as George mentioned, in a local area, engaging with a community of other people that are going through what you're going through. And what we find is that means that people feel that they're not alone in their challenges, and B, 50% of people that use our community go on and help someone else. So it also creates this virtuous cycle of peer support that has a lower cost of care. That means that we don't need to just simply scale up mental health support by scaling up counsellors. I should say, we do have 200 counsellors that deliver about 15,000 hours of support online in a WhatsApp style exchange with our users. So we're also not just about creating a digital download service, it's also about engaging early with professionals that can help you. Just one other thing to talk about is that although we are a digital service, one of the key things, perhaps 2 key things, one is around promotion and participation. So we have a team of 50 people across the country that are out there engaging with local communities, going to schools every day, aiming to really make parents, children, stakeholders really aware of the service, and also to help really address any concerns they may have. In Manchester, 60% of school children know about Kooth. So there is a lot to do with digital service alone, but actually a hybrid model where you've actually got it integrated into the local systems is really important. As is participation. That means the co-design of services to support specific targeted groups. So we work with Salford Boys Club, or work with specific charities focused on health inequalities, reducing those perhaps for Black young men, so that we can identify what is it that those types of service users need versus what we provide, so we can co-design services with users. And perhaps the last part to talk about is around data. Because our service is anonymous and at scale, we can essentially benchmark what's happening in Manchester with 16 to 18-year-old males versus the whole population. And in the last 18 months, this data has been invaluable, because ultimately the NHS today has two data sets they can look at for the health of the nation. One is a prevalence survey every 2 to 3 years. The other one is the waiting lists and people again referred in for specialist care. To give you a practical example, over the last 18 months, we essentially are the canary in the coal mine. We could see that eating disorders were on a huge rise. We've seen a 72% increase in people coming for support to our own service. That is now playing out on waiting lists. There's been a 50% increase. So part of what we're aiming to do, and anyone that's interested in this, join us, is building a data alliance. If we can connect the dots across different data sets safely with consent, we can help them provide predictive value to the healthcare systems, as opposed to just giving an insight. We could tell you that based on the data that we're all seeing, 3 months from now, there's going to be a surge of demand for these services. And if we could create a more connected, integrated set of data as well as services, I feel that that would address a huge amount of potential wastage in the systems, because we could target interventions based on where the need is.
Thank you. Thank you, guys. Thank you. Our final panelist is Helen Milner from the Good Things Foundation, who I guess gives the foundational perspective on this, on Maria, starting with digital exclusion and inclusion.
That's right. So Good Things Foundation, if you don't know about us, we're a digital inclusion charity. We work at a hyperlocal level in communities and also at scale. We've helped 4 million people to cross the digital divide in the last 10 years. And our goal is not just skills for the sake of it, it's to help people to be happier, healthier, and better off. I just want to tell you a story about hard to reach. So we're in thousands of hyperlocal communities, working with community centres, small local charities, libraries, some health centres, some GP practices, even a fish and chip shop down the road in Stockport. So I took a minister to a visit in a community centre, and he met lots of people, and then he said to the woman running this community centre, how do you find all these hard to reach people? And she looked at him and she said, what do you mean hard to reach? And he said, well, I've met an ex-offender, a single mom, a chap recovering from addiction problems. And she looked at him and she said, they just live on this street. Right. And then when he left, she said to me, I'm so sorry, Helen, I really messed that up, didn't I? I gave the wrong answer. And I said, no, you gave the right answer, because you told him these people aren't hard to reach. You were just looking in the wrong places. Yes. And so digital exclusion is a super determinant of poor health. We know, your map, actually, Lord Bethell probably also would overlay on people who are digitally excluded. So 90% of people who are digitally excluded are also socially excluded. Living with low income is the biggest determinant of digital exclusion. And of course, age, but it's the overlap between poverty and age. So for 6 years, we worked with the NHS on the widening digital participation programme. I still find that hard to say. And we helped over 650,000 people, primarily around digital health literacy. So this link, as Arpana was saying, between digital exclusion or digital literacy and health literacy. So by putting health literacy on the journey for digital literacy, we're able to reach hundreds of thousands of people who, I think it's fair to say, many of whom probably didn't think that's what they wanted to do. But because that was part of their digital inclusion journey, that they included that. And actually, we found that health was a great leveler, if I can use that word, that actually everybody was interested in health, like their own health, their children's health, their loved ones' health, that everybody has experienced a poor health somewhere amongst their loved ones. The other thing that we did with the widening digital participation program is a number of pathfinders. So deep dives where we could really look at the link between how do we improve health outcomes and how can digital and digital inclusion be part of that. So one example is in Stoke-on-Trent, working with the CCG for breast cancer screening, that they've noticed that the number of women, particularly from lower socioeconomic groups, weren't coming forward for breast screening. And we worked with them in a co-design way and then use Facebook. I think that Arpana that very point, that this doesn't have to be fancy. Actually, where are people with very, very low digital skills? Often they're on Facebook. And they had a chat to a nurse, and they turned around that decline into an increase in take-up from that group. And we also piloted something called digital health hubs. And again, this comes back to what Arpana was saying, is that this started on the high street in Nailsea in an old butcher shop, working in partnership with the local authority to say, if we put health advice, non-professional health advice, working with staff, but also volunteers who could be the interface between local people and digital information and digital services, and help to be that bridge, then would that work? And yes, it works. And yes, that former butcher shop is still there on the high street in Nailsea. And then we expanded that to another 25 digital health hubs. And the thing I'm most excited about that model is because of the bonding and bridging between the formal health system and what I like to call the informal health system. Like there isn't anybody on the panel from the NHS, but quite often when I am on panels with the NHS, they speak as if they own health, right? That they are doing everything to improve health outcomes, but actually that informal community sector is so important. I want to add that I'm very positive about the use of technology to improve health outcomes. Quite often people misunderstand that because I'm on the side of the millions of digital excluded people, therefore it's all about maintaining face-to-face services. I'm absolutely not about that. Basically because our charity scales, and you can only scale and have economies of cost if you actually put the money where it's needed. We don't need to have face-to-face services for the worried well, for example. But it's not okay that there are 10 million people who are digitally excluded in this country. So 10 million people with no or very low skills. We've got this beautiful infographic that shows what that looks like in this country. And unfortunately, the pandemic has narrowed the digital divide, but also deepened it. You can have that, of course. It's also not okay, as the Marmot 10 years on review, just before the pandemic struck, showed that not only had we not improved health outcomes for people in this country, but the people in those poorest communities, actually their health outcomes have got worse. And for women in the northeast of England, in the very, very poorest groups, their health expectancy has actually gone down by 10%. So this is not okay, and the overlap between digital exclusion and health inequalities is really important. But the good news is that I can't fix health inequalities, but we do know how to fix the digital divide. It's simple. You need to work on skills and motivation. You need to work in that hyperlocal communities. You need to work on devices, but also on data, connectivity. We're working with Virgin Media O2 on a national data bank and have £12.5 million of free mobile connectivity to give out through those hyperlocal communities. So I'm also optimistic, because if we can have action on digital inclusion, we know we'll also have action on health inequalities. And we know how to do this. And therefore, let's be optimistic. But I think a number of the panelists have said, let's make sure that we take the real opportunity from a crisis, and let's not waste this moment. Thank you very much.
Thank you, Helen. Now we've got a whole 11 minutes left for questions. I suspect there are quite a lot of questions from the audience. So the first, I'm going to in groups. The first hand up was the gentleman there in the red striped tie, then the gentleman there, and the middle at the back. So we'll do three together if that's okay. So I don't know if the microphone is coming unless you want to shout. It's up to you. So there you go.
Can you hear me okay? Thanks.
Yes, go ahead.
So my name is Rob Sargent. I run Optum's UK team. We support the NHS's flagship population health management development programme, the heart of which, of course, is absolutely about changing healthcare inequality. And we do that by going into individual healthcare systems and, first of all, linking the data, primary, secondary care, local counts, and so forth, and then using data and analytics to risk stratify and then identify what the next best action is.
Question is, Rob?
My question is, the challenge with these things isn't about the quality of the data or linking it, it's about information governance. And I, as CEO, find myself signing data processing agreements with individual clinical practices. My question to the panel, therefore, is how do we make the case that we've got to transform information governance if we're going to harness digital healthcare revolution to help with healthcare inequality?
Information governance. Thank you. If you could
Sorry to get there.
No, thank you very much. If you put me past the microphone to your right, this gentleman grabbing it from you.
Thank you. It's David McClenachan, patient representative. I'm on the Greater Manchester Digital Transformation Board. We've recently approved the use of wearables for cancer patients, which is a very exciting idea. I do have concern, and I'd ask whether you feel that the wearables might exclude certain groups. Certainly with scare stories on vaccinations, I can just imagine having a remote monitor tied to your body permanently.
So can I paraphrase your question? Is there a concern that wearables could actually exacerbate exclusion?
Yes.
Great, lovely. And sorry to be brief, I'm trying to get as many as possible. The gentleman at the back in the middle who's standing heroically seatless, Stokely all the way through, deserves a question for that, just for that.
Thank you. And probably as the NHS rep in the room, I should declare that I'm the London Regional Director for Digital Strategy and doing a number of the things we've just talked about here. But I wondered if there was anybody on the panel who had a view on the success and the future direction of travel of initiatives such as One London.
Thank you. So One London, discuss. Lovely. Right, I'm trying to allocate some questions here, some answers. So, George, would you like to do information governance? Since I guess this must be quite high on your agenda of how to get the public sector to make better use of data and information.
A bit, yeah. But I'd love to hear James's reflections because he's been right on the front line of it, and I've been out a bit. On David's point about exclusion, I actually think it's the opposite. I get the risk, but actually, if we can get more people digitally engaged with wearables, and it allows us then to focus the other resource on those who are hardest to reach in that sense. So I don't think it's a zero-sum game. In fact, if anything, digitalization allows you to focus your resource more on those who most need the help. Well, on information governance, look, I'd be very interested in James's answer, but the big point is, I think all of us who get where digital hits public services recognize that in the end you have to frame, you have to have a governance framework that at the top sets out some really key principles about protecting citizens and patient rights. And I think one of the exciting things about doing digital health is that you can do it through the values of the NHS, and that's universal and accessible. And when we launched Genomics England, I was absolutely adamant that we'd set it up as a company, so it could be agile, yes, owned by the Secretary of State, and that we would never sell a genome, never sell a patient record. It was a reference, a reference library, not a lending library. So we'd never transport out that precious asset. We'd invite people in to click and research. So there is quite a lot to be done on this. I just done a report for the PM on GDPR, AI, data in health, and how you get that balance right so that citizens and patients can trust the system. Companies, big and small, can participate in it, but everyone can do so with confidence. And that is one of the big challenges, by the way, in global healthcare. this country's got a chance, I think, to set some of the standards internationally. But I defer to James on, because he's literally come straight out of the front line of this.
Yeah, well, I have, and George, I think your point about getting the framework right is correct. I was very concerned that the IG debate was locked into a sort of unhelpful battle between NHS CTOs and privacy campaigners, and that is not going to lead us to success in this area. I have a suspicion that it needs to be a much bigger debate, and that people are going to have to understand what their health data really means. And until the CEO of the NHS is engaged in that debate and citizens actually have an idea of what, it might be a passive idea. Like, I'm pretty passive about my Facebook data and my Google data, to take James's point, but at least I feel I am in a safe place. I think people are going to have to be much more engaged in their own healthcare data, and we've got to take it out of the hands of the technologists and the lawyers.
Thank you. I'm going to get a quick thought from Arpana on wearables, and then I think we might fail you on the One London point. I'm not. Nobody on the panel has left on that so far. So come and see the panel afterwards. But we'll give you a bespoke answer. But Arpana on wearables.
Thank you. With wearables, I think there's a huge opportunity here for really thinking through narrowing the divide, because I think wearables offers the opportunity, if we do it properly, to actually think through those large sets of data for population health, which we just don't have. I've looked at falls prevention and the key wearables for air pollution monitoring. And we know that where we have inequalities, there we have people who are less able to do things to mitigate against the risks that they are exposed to. And I see wearables as something that will actually allow us to not just measure, but design interventions. And I think Helen and some of the work that they've been doing has really overcome some of those barriers that will be able to help us on the prevention agenda.
Thank you. Now, we've got a whole 4 minutes left. I'm going to heroically try, or you're all going to try and get a round of questions in. The panel will try. We'll answer with asperity and crispness, and we will all wrap up by 11 o'clock. So I've got 2 hands up. A gentleman there, and one in the back, far back corner from where I sit. So these will be magnificently brief questions and even more magnificently brief answers.
Thank you. Just keying off the stuff that George Freeman was talking about around transparency in health and communication, and also the mental well-being. What's the panel think about supporting the NHS staff with the consequence of COVID, the emotional burnout that they're suffering? How are we being open and empathetic with them as leaders in healthcare?
How to support staff, and I think, is that Richard? I can't.
Yeah, hi everyone, Richard Sloggett, Future Health Research Centre. Nice to see everyone. Just a quick question on primary care, which I think are absolutely critical to this agenda. Big debate going on about face-to-face appointments versus digital appointments. And I just wanted to particularly get ministerial views on where you see that agenda going next.
What happens next to the face-to-face? So, shall we do the support for NHS staff first, and then we'll get the ministerial upsum on face-to-face? Is that Tim? Is that okay?
Yeah, happy to talk about that. I mean, as we all know, that burnout, stress and strains, those stresses that NHS staff and teachers and other support workers have had. Obviously, there's been an initiative to focus on hubs, basically to support NHS workers. I think the main brief answer is it's all about choice. We support NHS employees in some of our contracts, let's say in South East London. 50% of people use our service outside of working hours and weekends. So essentially, there isn't a universal approach that you're going to support. It's about choice and then targeted approaches.
Thank you very much. Now I think we've got two minutes left, so I'm going to give 1 minute each to Helen and George on this point, if that's all right. And then if you leave any time left, we'll get a last thought from James. But Helen and George on this, on primary care and the merits or otherwise of face-to-face versus digital.
So my answer actually to both of those questions and the one about wearables is about co-design, and not make any assumptions. So let's not assume that certain people want face-to-face and others want digital, but actually if you get to the root of the barriers for the people asking for face-to-face, and similarly, what support do NHS staff need? Of course, they need support, but let's make sure that we co-design and we don't make assumptions, and that we understand that help for skills, for proper induction and proper implementation is absolutely needed for these services.
Thank you, George. On the understanding that this is you, you're not. We can't hold you accountable for primary care as a business minister.
Yeah, thank you. Look, I think they're both linked. Firstly, there is a huge problem in terms of morale and wear out and exhaustion in our health and care service. I see it in my constituency, and of course, in the end, what people need is a bit of a break, a bit of acknowledgement, a bit of a thank you. It's quite difficult for the machine to do that. They actually we all need personal management. And I think that's really hard. The NHS has become such a huge machine that it has its own internal culture that I think a lot of our staff on the ground feel as though they're climbing up a mountain and they can't see it getting any easier. And I think it's linked because many of those staff, I would love them to be using some of these digital programs and getting on some of these apps. And I suspect that actually what happens in the medical community very often is that they look after themselves. And actually, I'd be very interested to know if anyone's got any insight on this, but I think this is a chance to mainstream digital mental health support, health services through the NHS, through this post-COVID surge. And on Richard's point, I have a really good GP practice, and I just observed that at least half of the things that we have to do together, I would rather do it digitally, and I think they're beginning to think they'd rather do it digitally. Some things, it's probably more like 80-20. 20% of the things I actually want to go in and sit down and talk to somebody else. I think that's broadly true, and if we can get the 80% digitally, we'll do it quicker, more easily, huge savings, which will help release pressure on the poor people on the front line and allow the face-to-face bit to be done better. I think everyone is beginning to accept we can do that now.
Thank you. Now, unless you've got a 30-second thought, I will have to wrap things up.
On the staff, huge pressures. I don't underestimate them. But we did some surveying of what was good about COVID, trying to find a positive thing. And one of the things that staff said is that they felt that they were given responsibility to take the initiative. And that was something that was a really profound feeling among staff. I'd really like to capture that and to not go back to the old ways of doing things. And I think that the jobs can be a lot more rewarding and people can get through a lot more if they feel that a greater sense of ownership in what they do. And on face-to-face, it is absolutely the totemic innovation case study that comes out of the pandemic. We've got to get this right. George is right that it's fine-tuning, it's 80-20, it's not quite perfect where we are at the moment. But it is so important we nail this one because it is the one example of where a complete revolution has happened in months. And it's a really good example of how change can happen in healthcare.
Thank you very much. Now, with that, I'm going to thank all of you for coming. I'm going to thank our panel, and I'm especially going to thank Policy at Manchester for working on this event. But maybe before we shuffle out in orderly fashion, we can give a hand of thanks to all our panelists. I'm now 3 minutes late for you to share things about pensions.